and I'm going to talk a little bit about some of those. And I fulfill a media and ambassadorial role. One of the things that we as doctors and dentists who are working in healthcare don't necessarily realize enough about these days is the power of the media and social media to get change to happen, and the importance of influencing in order to make change happen. And I'll talk a little bit about that later. So the MPS needs to keep up to date. It would be very happy to be like, do you know the song, Sing a Song of Sixpence? The king was in his counting house counting out his money. That's what financial services organizations do. They sit in their counting houses counting out their money. But actually, if we look at the NHS, we need to keep an eye on what's happening in the NHS. So this is a piece of work that the Royal College of Physicians did in 2012. But if you read it, it's still the case now. And in fact, it's much worse now. So most people who are admitted to hospital are over 65. Is that true? Yeah? Yes. Yeah. Primary care is struggling. It was struggling in 2012.
Dying.
It's dying in 2023. There are fewer beds, and they've been reducing over 25 years. There's an increase in emergency admissions, and we have nowhere to put them because there are fewer beds. And also the patients that come in are more complicated, because as we've become a victim of our success because of public health, people are living longer. And as they live longer, they don't just have one condition, but they have 1, 2, 3, 4 conditions, and they live until they're 85 or 90. So we've been a victim of our success in the health service. And that's before we start thinking about technology and artificial intelligence. So does anyone think artificial intelligence is going to make things worse? Yes? Anyone think it's going to make things better? Yeah, it's going to make things different, and we're going to have to adapt and have to cope. And I suppose what I'm saying here from the perspective of the MPS is that we are in a moving environment in health. And if we want to be able to influence what big organizations do, we need to be able to make people aware that we're in a changing environment with a lot of things happening all at once. So the MPS has got to keep up to date, and I see that as part of my role. The biggest problem, I would say, in the health service is the workforce. And that's from a few years. So I've been working in medical politics and at the senior level in organizations for more than 10 years now. And it seems to me that every crisis that there is in the health service can be tracked back to there being not well enough qualified healthcare professionals, or the wrong kind of healthcare professionals. And the workforce is the biggest unresolved issue in the NHS, and it's one that has been ignored for years and years and years. And the reason why it's been ignored is because to have an adequate supply of healthcare professionals would be too expensive. So if we had enough doctors or dentists, it would break the bank, and the bank's already broken. So one of the really interesting and positive things is that I worked a lot when I was at the Royal College of Physicians with Jeremy Hunt. So who likes Jeremy Hunt? Oh, nobody put their hand up. I like Jeremy Hunt. I like Jeremy Hunt. So I worked with Jeremy Hunt on the Health and Social Care Committee, which, because I have a job where I evaluate government pledges. And he was the person that recognized through battles in 2016, when I was the president of the Royal College of Physicians, that actually the workforce mattered and that we should do something about it. And he was the person, strangely, who got the NHS long-term workforce plan over the line. But he couldn't really say that he did it, because by that time he was the Chancellor of the Exchequer, and he knows that it's going to break the bank. And so he couldn't properly promise it. So the problem in all of that is that the workforce plan is properly funded for 2 years only, and then it'll be evaluated. So he could only get 2 years promised. So we may still, or we're likely still, to have workforce problems. But to get back to what I was saying, there's actually a worldwide shortage of clinicians in healthcare, particularly doctors. There are a very small number of countries that overproduce doctors for export. GMC doesn't always let them in. Cuba. Anybody know anywhere else? Philippines for nursing. So people say that India does, but actually it doesn't, because it just has such a huge population it needs to keep all of its doctors. Have you got, do you export?
I mean, we've been training some private universities, and there is more doctors in national places.
Yeah.
For placements. So they have work somewhere.
Yeah. Another place is Lebanon. Another place is the Caribbean. A large number of resource poor countries are now creating doctors as a growth area. In this country, sadly, the numbers of doctors that we're allowed to pop out every year, I used to pop them out. I used to pop out 400 a year. Felt like a big midwife. 400 a year for UCL Medical School. But our numbers at that stage were capped. Does anybody know how many doctors a year come out? How many qualify a year?
8,000?
Yeah, it's about 8,000. It was 7,000. And if we, as a medical school, if we pop out too many, we get penalized financially. So we can't increase the number of doctors that we pop out in this country. So we're reliant on immigration of doctors to fill the gaps that we have. And there are all sorts of problems with that. Sorry? I don't know the number, other than that it's going right up because of the pension pot difficulty, and because people are fed up of the working thing, and the age profile as it is means that the doctors are gradually getting older, and they've tended to be, for economic reasons, better off than the younger generation, so they're retiring early. So we have a problem. And so the workforce plan says, well, why don't we double the number of people who go to medical school? And that's what's in the process of happening. But also, there's a huge controversy at the moment about PAs. Do you know about the PA thing?
Yeah.
What do you think about the PA thing?
Well, they wiped out the local market for PPs.
Have they?
So, over a space of a year. And not only London, but nationwide, but local.
Well, you see, some of that actually can't be true, because there aren't enough of them to do that. Because the numbers that are coming out of PA school are really very small compared to the numbers that are coming out of medical school at the moment. But they have a huge potential to do that. And there's a lot of fear on social media that they're going to be taking jobs. There seems to be this really odd thing that they start on a higher salary than F1s, which really makes everybody cross. And they also have less of a training program. So the solution to all of that with physician associates is to regulate them. No, there aren't that many anyway. Yeah, they're not around. Yeah, they're not around. There really are not enough of them for us to make the fuss that we're making about them at the moment, I would say. However, they need to be regulated, because I think some of them quite like the idea of pretending to be doctors. They quite like earning, starting on a higher salary than doctors. And they quite like it when people think they are doctors. But if they were regulated, certainly the misuse of the term doctor, which is a protected title, would stop. The salary's got to be sorted out with either national terms and conditions or within trusts. But where they're not regulated at the moment, there's nothing we can do about any of it. So the whole thing's turned into a media circus. And the problem is that when we were first saying we haven't got enough doctors, and we're now saying we don't want these people, thanks, we're not sounding very sensible. But
they're not independent clinicians.
they're not.
Actually, it does add to my.
Yeah, it does, because
I'm responsible for them. I supervise them. So ideally they were to help us, but
yeah.
in fact they are a responsibility,
Yeah.
and they are the workload.
So the plan with them, and the Royal College of Physicians actually houses the Faculty of Physician Associates, and they did it specifically to help to get them regulated. And what's happened is that the regulation has been so slow. So I've spoken to the head of the GMC, both the chair and the chief exec of the GMC. For goodness sake, regulate them. That would solve so many of the problems. And they say, oh, it's just too complicated. It takes too long. The government is really sitting on its hands and not putting it up the legislation list. And they don't end up being regulated.
So I can compare it with ongoing problem regulating aesthetic medicine. Yeah. People doing Botox after 1 day of training for years and years not being regulated, and really harming. They can harm.
Yeah.
And it's another example, like there's people, politicians, and the government are slow. They've been informed many times.
Yeah. And for us, it's potentially doctors on the cheap. And the trouble is, I suppose, maybe you have to sort out some of the problems with aesthetic practice. There's no regulation. So yeah. Actually, one of the things I was proud of at the College of Physicians was on a Friday when nobody would hire out the premises when I was a younger member, all these Botox people would come in and hire the building and wear what looked more like doctors' uniforms than what I would wear, and run the day course. So I said, we can't do that. We can't do that. Yeah.
What I said about them wiping out the local market was very much a repeat of what I read, and partially of what I see in the local market in London happening. And you also mentioned the role of social media in all of that. So what we see as doctors in the local market, that's not because of PAs and AAs. So there's something else happening, whether that's just surgeries maybe not getting enough money to hire temporary staff, or they just for some other reasons.
So in primary care, is that?
Yes,
in primary
GPs.
Care. I don't know. I suspect that it's variable across the country. Well, there's. Yeah. No, it isn't a very small amount.
No, but they don't do locums. They are sitting at the surgeries doing jobs, so that's why the surgeries don't need so many locums. This will help certainly.
But it's not just PAs. Yeah. There's something called the ARRS.
There's pharmacists, paramedics, nurses, prescribing nurses.
So there's all sorts of people.
There's a huge movement, and they are taking over here slowly.
There are all sorts of people, and those are being subsidised by the government to help support general practice, to help support the ARRS. Additional, I can't remember what it is, but there's a government scheme that allows paramedics, ambulance workers, allied health professionals, pharmacists to all be paid to work in GP surgeries to support. But the reason why they're there is because GPs are struggling, dying, and so they need the help. Did you have another?
Yeah, I do actually. I was just looking and trying to compare the sort of the educational structures that we have for undergraduates and those for PAs. And the ones for PAs are much less structured, much less well developed. And I know that each academic institution will be trying their utmost to get the best level of education, but there is no consistency from what I'm seeing in the educational process of PAs. So that's still got way to go in order to maintain standard, I would feel. The other thing that I was about to say is, with this workforce plan, and yes, doubling the amount of doctors, and that's the numbers that we've got to produce. but yet there are only a few new medical schools and only a slight loosening of the numbers that we are allowed to take in before capping, and that's certainly not going to meet demand. So I'd be interested in your comments on that, because it's all got to be structured, there's got to be provision, it is going to be expensive, but we've got to, because we're not going to meet demand.
Well, the answer is yes. So the lack of the inconsistency in the training programs is interesting, because what happened, because they're unregulated, so you can't just make up a medical school. You have to be regulated by the GMC. But if you wanted to set up a PA course, you just set up a PA course. And so with students paying who get into medical school or wanted to become PAs for other reasons, there are courses that have just set up and they weren't regulated. So what the College of Physicians did back in, I don't know, 2015, I think it was say, look, we can't have this. Therefore, they housed the Faculty of Physician Associates and they set up a national exam, so that even though all of the courses were completely variable, they would all have to take one exam. And so people have been trying to standardize, but it was like the Wild West when it was set up. And the problem is that there's huge demand because there aren't enough doctors and we can't get enough through in time. Yeah.
I was just going to say that there's a recent case that's really quite high profile, you're probably aware of it, of a patient who was seen with chest pain, and it turned out aortic dissection, and the patient was sent home with proton pump inhibitors and some pain relief. And that patient was discussed with the consultant, I think, but it was a lawyer who died, 25. So I think if there are more cases like this, it's going to be a major issue for these PAs.
That makes me feel uneasy. It makes me feel uneasy because who can put their hand up? I can't, to say you've never killed anybody by accident if you are a doctor that's worked for a long time in the NHS. And we pick out those cases, but actually we've all missed a pulmonary embolus if we've done acute medicine. We've all missed a cancer if we've been in primary care and we've been looking at difficult to diagnose things. So, I don't think we don't have the data on that yet. But it's a legitimate concern, and you're right. But even with a junior doctor, if you see something and you get it wrong, and then you present it to your consultant, if the consultant hasn't actually seen that person and evaluated themselves, you still might get it wrong. So I think it's difficult to. Oh dear, I've talked so much. The computer's gone to sleep. Screensaver.
So may I ask, when it comes to physician assistants, are they completely independent, or if they make a mistake? So if they are, if a doctor is responsible for physician assistants and they make a mistake, then it's probably quite difficult when there is a claim made, because exactly.
I do supervise them as a duty doctor, but then they don't discuss every single case. So they could discuss with Dr. Barber, and who takes the responsibility?
Please use microphone.
You do.
So we are responsible for those poorly.
Yeah, so that is a big risk. Exactly. So they're not called physician assistants in this country, they're called physician associates. Okay. But they are meant to be, they were set up as dependent practitioners, which means that they can't prescribe and they can't order x-rays. So they have to be supervised by another member of the team.
And they can provide advice. And that can be dangerous.
So they could, yes. So we're in a pickle, aren't we? Because we don't have enough of us. We can't do all the work that needs to be done. There's this whole load of people that potentially, but not yet, are coming in and they're not regulated. And they're doing our jobs, but then we take the bind. No wonder people are upset. So I don't want to spend the whole morning talking about physician associates, but shall we just take another couple of comments or questions, and then I'll Oh, there's 3 more, so nobody else is allowed to put their hand up. So,
Sorry,
yeah.
Professor Dacre, in regards to the physician associates, are there really talks of addressing the name physician associate? Because I have nothing against physician associate at certain roles. They do help the system. I've worked with them in same-day emergency care, but from patient safety perspective, they never correct a patient when the patient addressed them as doctors.
So the Royal College of Physicians issued a statement earlier this week after their council meeting where they got a beat up from their council, elected council members, that says that a physician associate should introduce themselves as a physician associate and should not allow the patient that they're seeing to think they're a doctor. But at the moment, the GMC says, oh, well, we just regulate. That means we don't really have anything to do with the day-to-day. And the colleges don't, at the moment, realise that it's their responsibility to make those rules. And those rules are not clear because they're not regulated. So that arrangement hasn't been set up like it has for doctors. So yeah, we're in a pickle with it. And wait till we get apprenticeships too. That are also in the NHS plan. I think the microphone's gone somewhere else. Yes.
Thank you. So mine might be a slightly weird question. I'm old now. Almost,
probably not as old as me.
No, almost. And I would like to return to clinical medicine under strict supervision, but that is almost impossible for somebody like me who's practiced in public health. So I could be somewhere in between. Or retrain, not retrain, because I'm too old to do that. But I'm sure that I could undertake a good medical job, but there is almost nothing because the GMC wouldn't allow that. I mean, there are some associate specialists, but I think with all the doctors who are retiring early, there could be a way to return and to do something useful under supervision. Do you know what I mean? We don't want to be consultants and we wouldn't be GPs, but I still have a lot of clinical knowledge, and I would be very humble and under somebody else, but I could do something useful, but there's no role. It's almost impossible
to get back.
Yeah, so I'd be
that
better
is
than a physician assistant, I think, but not completely independent.
Associate.
Sorry. Yeah.
Well, yes, absolutely, and there is a plan to try and make it easier to get back onto the register once you've retired. At the moment, it's or to change what you do, but they haven't been able to regulate physician associates. There's such a big to-do pile that these things just take years and years and years and years and years. I mean, the things that the GMC do, they do very legally and very well, but very slowly. So they have a whole big to-do list, and they just haven't got around to it yet. Yeah.
So all the problems you're describing, aren't they due to the fact that there's a monopoly employer in this country? Everybody's employed by the NHS. So that's why you can't have more medical students. That's why you're having doctors on the cheap in terms of physicians associates. If you had a different funding model, actually, you might find that actually provision was better.
Okay. I'm not equipped to answer that question. However, there are very clever people around who work for think tanks like the Health Foundation and the King's Fund and the Nuffield Trust. And they tell me that that isn't the solution. So maybe I went to the wrong one. Maybe I went to, but everybody's going to. But the other thing is, if you paid for care, or if you paid a contribution to care, would that help and would that reduce unnecessary demand? Again, the think tanks don't. They've done economic modelling and they say no. So I don't know. But I think if we have these views, we should discuss them. I'm going to move on because otherwise you're going to miss your lunch. So I'm going to look at. I mean, this has really piqued everybody's interest as far as I can tell. And so what I want to do now is to look at some of these issues through the lens of me working within the MPS. So I'm going to focus down a bit about what the MPS does, because that's what Halima asked me to do, but I couldn't resist talking about some of the other stuff because it's really interesting. So the first thing is the kinds of cases that you might have difficulty with and you might need to go to a medical defense organization. The second is the common areas where doctors find themselves at risk. And then I'm going to talk a bit about, in this hostile environment that we find ourselves in, how do we protect ourselves? And then just to pick out, to highlight some of the things that I try really hard to get the MPS to be interested in, which is things about the well-being of doctors as opposed to the well-being of their wallets or the MPS's wallet. So I'm going to look at that. So the kinds of cases that doctors get are complaints from patients that they have concerns about, disciplinaries where they've done something wrong and they're in trouble with their trust for a disciplinary process. If they're under investigation from the GMC, so most of the people who are referred to the GMC or the regulator are actually referred by the organizations that they work for. Clinical negligence, that's when something goes horribly wrong. And in this country, you can only get compensation by proving clinical negligence. And that's something that, again, the government maybe should look at and should take 500 years. And also criminal investigations. So if a doctor crosses the line and is being investigated criminally. Now, the interesting thing about the medical protection organizations is that unlike car insurance, they don't have to cover you. So if you were, if you were Patterson, that chap that did dreadful things to women and was convicted and went to prison for doing cleavage-sparing mastectomies and essentially operations that he'd made up. The Medical Defense Organization is not obliged to cover the costs of that investigation, and then sadly also the costs of the damage to the public. That has to get picked up by the NHS. So those are the different kinds of cases that people get referred for. And the most common areas of risk are actually about communication skills. And interestingly, there's a big increase in complaints about communication skills where English isn't the first language of the doctor. And so I thought I would mention that here because that's a common area where as people for whom English is not your first language, you are, through not necessarily any fault of your own, at risk if the patient hasn't understood what you've said. But also haven't understood what you've written. There are all sorts of jokes about doctors' handwriting, and recording what you do in the notes in a way that people can understand it is really, really important, and is something that we, if you're trying really hard to save somebody's life and then you go back afterwards and you write it up, you often don't record it as well as you should. And is that better now that we have electronic medical records? It's just different. It's just different. Yeah.
I think the problem is that we've lost our secretaries now, and recording our electronic record becomes a much bigger process for us. It takes up so much more admin time.
Yeah.
They would pick up, and so you get a bit shorter in writing your records. Yes, we're now being told how to get voice recognition and all these tools we give them. But we haven't got our secretaries in.
Yeah, and also with the change to electronic medical records, I certainly find that if I've written something down on a piece of paper about a patient and I see what I've written, I know who it is and I know what I'm talking about because my limbic system or something tells me the answer. But if I just see a set of standardized things written down on a computer screen, my recall is less good. So there are a number of areas where it's difficult, but these are common areas of risk. And the other is a lack of understanding of consent. So with a lot of doctors that end up in serious difficulty, the problem is with consent, particularly with surgeons where they've done more than they said they were going to do. And the patient didn't understand that they were maybe going to be sterilized at the same time as their cesarean section. etc., etc. So when patients find things out afterwards. So those are the three, and this is from data that is kept by the organisation, and it's kind of not rocket science, but those are the three commonest areas. But if you work in the NHS exclusively, most of the complaints are covered by your NHS trust. However, the thing that people don't necessarily understand is that it's not everything. So things like regulatory matters or private work are not covered, and some people don't understand that, and they feel that they are covered by the NHS when things go wrong, and the answer is not completely. So you do still need to have some other kind of support for things like personal complaints against you, referrals to the regulator, etc. So, and that's something that people who come into work in this country who haven't worked here before, who aren't doing any private practice, don't understand. But the trouble is, they're more likely to be referred, and they're not covered if they don't have separate defence organisation coverage. So this is all about how to protect ourselves, really, against claims. So this is just to highlight, there's a list of things that people can request, and those that have a red box next to them are not covered by the NHS. I'll just give you a little bit of time to read it. So some of it is, but some of it isn't. So also protecting ourselves, one of the groups of people that has most difficulty with complaints and referrals are international medical graduates. And a lot of, I mentioned before that a lot of international medical graduates, when they're new to this country, think that they're covered by NHS indemnity, and they're not. And so they do need to understand that. And so what the medical defence organisations have done together with the BMA and the NHS is to come up with an induction programme that says, look, these are the things that are most likely to get you into trouble. And you probably ought to join a medical defence organisation because you can still get a complaint that you would be liable for. And that's particularly the case with, so for example, all of these doctors that might come from Poland that starts exporting their doctors, but people who come from other countries don't necessarily know that. And then, of course, there are ways to reduce your risk, which is that make sure people in there, when they're doing their CPD, they tend to learn about their own specialist subject. They learn less about the things that get them into trouble. So do remember that with your CPD, there are some things that you need to do that will help keep yourselves out of trouble to reduce your own personal risk. So I'm going to talk a little bit about advocating for doctors and influencing. So I'm a great believer in what's called soft power, which is where you talk to people at your own level and you socialize ideas about change that need to happen, and you talk to those things to the right people, and then it becomes their idea and then they make the change. I'm afraid it's probably a bit gendered to do things like that. But it's a way of getting things done, and it's one of the things that I've been trying to encourage the MPS to look at doing in order to support doctors without standing on a soapbox and shouting out about what should be done. And more these days, because healthcare is so complicated, so complex, you get change through soft power rather than actually being in charge. So GMC reform, we've talked a bit about the GMC. So the GMC has an enormous agenda and a huge number of things to do, and they're not in a good place with the profession that they regulate at the moment. I don't think I'm being unfair on them to say that. I think they try hard, but they're not in a good place. And things started to be more difficult when there've been index cases. And does everybody know who this lady is? Yeah, who sent shockwaves through all of us about how we were all potentially vulnerable. So the first thing that the GMC are trying to do and taking ages, and the MPS is trying to help them, is to give them more discretion about how to investigate a complaint, because some of the complaints that they investigate sound a bit daft when they get into the newspapers. Can you think of any? Yes, the lady who was offered a computer and she thought she was promised a computer, which is probably a language thing, and she got sanctioned for 6 months, didn't she? There was another one. There's another one silly. So do you think the GMC is fit for purpose? We have to have a regulator. We have to have a regulator. And they feel that they're better than some of the other regulators, but I think they need to change. Yeah, yeah, yeah. And I think I read somewhere that the percentage, something like 10%, is really high. So it's Terence, yes. Yeah, he's been investigated a few times. Yeah, yeah. So the idea of giving a bit more discretion to say, do you know what, this silly. The other one was the Oyster card man. So I took a GMC MPTS member to task about that. So, what are you doing? What, you're just going to end up on the front page of the papers for being unfair. But apparently he'd done it a lot of times. Well, even so, I mean, who? For goodness sake. Anyway, so those are examples where they have done silly stuff. So they need to stop doing silly stuff if they want people to say they're fit for purpose.
Especially the sanctions are so severe because we aren't thinking if I was suspended,
yeah,
and lost my income, I don't know what else.
Well, and if you look, just to digress a bit, if you look at risk factors for suicide, just interestingly from another thing that I've been working on, it's really hard to predict who is going to commit suicide successfully, and actually often sudden financial difficulty is something that drives people who were not suicidal, as far as anybody that was in their family knew, to do something awful. I'm going to move on from that. So the other thing is remove the right of appeal. So the Bauer-Garber thing was because the GMC appealed against a more lenient decision that was made by the Medical Practitioners Tribunal Service, and that's what caused a lot of the uproar. And so in the Norman Williams review of the Bauer-Garber case, they said that the GMC's right of repeal should be removed. And they haven't done it yet. And so the GMC is still appealing against their own cases. And so the MPS is pushing and pushing. It's like pushing porridge up a hill, trying to get the right of appeal removed. And they say that legally they have to appeal because that's what it says in their statutes, and nobody's changed their statutes. And we say, well, can't you just appeal less often? They say no. And then the other thing is to improve its processes, because some of the stresses is how long cases go on for, because they go on for years and years and years before the doctor is exonerated. And so to put pressure on them to try and, first of all, don't investigate silly things, and secondly, only go for investigations where it's really serious. And when they are doing it, just get a move on and get it done quickly. And that's the 1 in 3 doctors. This was we've done from the MPS. We've done various freedom of information requests to the GMC, and 1 in 3 doctors referred do think about taking their own life. Another thing that we've been doing in MPS is looking at making doctors feel more robust psychologically, so working on burnout and working with employers and organizations on how to prevent burnout, to recognize that it's happening. And there's been a lot of issues with burnout since COVID, and to think about well-being. Also, they now have a 24/7 counselling service, so you can ring them up anytime, and the medical protection organisations are trying to provide that support that people don't feel they're getting in their workplace. Yeah, yes, because the people that speak to you, well, not always, actually, there's a bit of a whole physician associate things going in the medico-legal offices. They're not always doctors, but they always have reference to a doctor. They're running a campaign about the menopause in the workplace, because as the profession becomes increasingly feminized, they don't, the workforce, and I can say this from the own work that I've done, the workforce structures that we have are designed around a man who started their NHS career in 1948 to 1950, and they haven't kept up to date with the different needs of a workforce that's got a group of different people in it. So we've been working on that, and also a well-being support for members. So a lot of organisations are trying to look into the NHS to provide support that isn't provided by the traditional organisations. International medical graduates have a particularly difficult time. They are referred in more. They don't have good induction. They're chucked into locum positions in hospitals where they don't, they're not told anything about it. They're given huge clinic lists to deal with. They have computer systems that nobody tells them how they work, etc., etc. So we've been working a lot with trying to support international medical graduates. And just some statistics here that this is where, if you don't have proper legal representation, if you're not represented by a medical defence organisation, you're more likely it's more likely if you graduate overseas that you'll be referred. And then if you don't have representation, you're far more likely to be at the wrong end of the results, so to be struck off. Oops, I'm too far. So one of the other things that a lot of people are talking about now that's come out of Bauer Garber is that when something goes wrong, the system that we have and the regulatory system that we have blame the individuals. But actually our hospitals are in such a state, and there are so many rota gaps, and there are so many things like having to support lesser trained professionals that you don't have any shout over, that we're trying to encourage the GMC and other organisations who say they are doing it to actually look at the wider system. Don't just look at the doctor who ended up the one carrying the can, particularly if it's an international medical graduate. And actually what we need to be encouraging within the profession is not a culture of blame, but a culture of trying to work together to sort things out. And patient safety research, as all now says, you shouldn't blame the individual, but we still do. Yeah. Yeah. Yeah, yeah, yes. It makes it very difficult also to pull up people that they'll lose their jobs. Resources or whatever, being suppressed by the management structure. Yes, yes.
I would just enforce that point. A lot of trusts now are using referral to the GMC as a way of controlling doctors and whistleblowers in particular. Willetby's one case, I think. There's Morecambe Bay. There's many cases. Yeah. I think Queen's in Romford had an issue there.
Yeah,
huge numbers of doctors being referred.
Yeah, so that's part of the soft power thing to say, look, don't just refer, people to the GMC if you don't like the cut of their jib. There's got to be a really serious case. But the culture has been that people can't deal with it locally, or they feel it's difficult with the NHS complaints procedures, so they just say, right, we're going to refer you to the GMC. That doesn't help anybody.
So what about some sort of regulatory body for managers? And I'm just thinking about the special care baby unit and the consultants who are trying to raise the Lucy Letby case.
That's one of the things that's come up in with the. That's one of the things that's come up in the Letby case, isn't it? That managers aren't regulated. Personally, I've thought for a long time that managers should be regulated. They could just get to go and work in a different trust. Yeah, I agree. That's another debate. That's another debate that's going on. And a lot of these things have been thought about, have been mooted, have even been suggested to government, but haven't happened. Yes.
So I think part of the problem has been the last, certainly when I qualified and just, seeing this over the last 3 decades, is doctors having less and less say. I mean, it used to be the other way around. And I think if this carries on, we're just going to be in a worse position in 10 years' time. I think in the US, something that I think, I mean, you can speak to this because you did a sabbatical for 2 years in Texas, but, we can argue the pros and cons of the US versus the UK system. But I think there's much more emphasis on doctors with MBAs running medical institutions. Yeah. And I think that, that makes sense, that you should have that sort of authority and understanding both in the business side and in the hospital running and the management side. We don't have that in the UK, and I think we're struggling increasingly with that lack of professionalism.
Yeah, absolutely. It's actually really hard to get an MBA as a doctor. When I ran UCL Medical School, I tried to set up an MBA. So where you do your MB, but we couldn't get it. We couldn't get the regulations of the universities changed to allow us to do it, because for an MBA, you have to have done your first degree and then worked in industry for a couple of years and then gone in at master's level to an MBA program. And as a medical student, you haven't worked in industry. So there was this real computer says no structural thing in the universities about not being creative about the way that people do it. So if you want to do an MBA, you have to do it as a postgraduate study and take time out of your life as a doctor. I have to say Steve Powers has got an MBA. He's done all right. But, some people have, but the majority haven't, and it's not the norm, and it is in the States. And you're absolutely right. A lot of people say that if we had a bit more control. But we maybe have ourselves to blame too. We've gone up the alleyway of virology, haven't we? There are few doctors, which is, I'm actually a bit unusual in having become really interested in politics, and I've done that because I just saw that so much was wrong. It wasn't our fault when I was at the College of Physicians, but a lot of doctors are not interested. They when things get tricky for us as clinicians, what do? We feel good about focusing on the patient in front of us. And actually, we don't step back and look at the wider system and look at how we could influence the policy levers. So we have a bit of collective responsibility, I would say, to move the dial on that. But well, is it? Because the BMA is a trade union, actually. So the BMA should look at terms and conditions. It probably should be the medical royal colleges that look at standards, but not terms and conditions. Yeah, be careful how long you think. Yeah. Yeah, we have.
Our representation is through the colleges, the college of surgeons, college of physicians, etc. And have the colleges.
I think it's very interesting. It is very interesting being at the head of a medical royal college. So I was at the head of the College of Physicians during the last junior doctor industrial action. I haven't put it in here, but I fought hammer and tongs with the government around better rights for junior doctors. And it was actually really difficult. And at one stage, I was isolated. I was told, right, we don't want you in. We don't want you to come to our meetings. You're too troublesome. By Jeremy Hunt. But what happened, fortunately, well, not so fortunately, maybe for some people, they then nearly lost an election. And so the politicians suddenly said, you know what you were saying? Maybe some of it wasn't so bad. Would you like to come back and talk to us again? So it's a very difficult relationship. And the government, I don't know how far is this recording going? The government that we have. No, don't worry. But the government that we have is dysfunctional. And if anybody wants to see how dysfunctional the government is, read the book by Ian Dunt that's about how government works and why it doesn't. And the structure of the UK government hasn't, a bit like the NHS, it hasn't kept up with the needs of governing in the current climate. And there are several things that are wrong, like the politicians who reach high office don't necessarily know what they're talking about. Well, yes, you might. You might. You'd certainly say it about the states, wouldn't you? Yeah. So we can record it. All right. But I think I need to come to the end, but then very happy to chat until you've fed up and think your lunch is going to be spoiled. Because I want to just finish by saying that health systems are struggling around the world. We're not the only ones. You're quite right, Helena. We're not the only ones. They're understaffed, they're underfunded, they're overstretched everywhere. Patients are sicker. The doctors and other healthcare professionals, including actually the poor old physicians associates who are getting it in the neck for not being what people wanted them to be, are at risk and need support. And there's a limited number of organizations that can support. And so that's why I work for the MPS. And I think probably you've had enough of listening to my voice. And do you know what this is? What is that? So that's the lettering. So the logo is the logo of the Royal College of Physicians. And it is a hand coming down from the heavens and feeling a pulse. And underneath it is a pomegranate, which is a symbol of health. And that is to finish on a positive note, to say that governments come and go, organizations come and go, but healthcare is one of the most important things that any of us ever do. And the Royal College of Physicians has been in existence since the time of Henry VIII. And so the physicians as a group, so physicians in their widest term, as a group of influential professional people, have been around for 500 years or more. And we're in the doldrums at the moment, but I think in 500 years more, we'll still be here. Things will be different, but we'll still be here. So we have to hang on to that. But I think in order to make it better, we have to be prepared to stand up and be counted. And people have to be prepared to get interested in the politics of medicine and to make it better. Thank you.
Thank you very much for fascinating lecture. Thank you so much for coming and being here. Halina is going to present you with some token of appreciation. Thank you so much.
For us, I hope everyone enjoyed it. I would like to express our gratitude with the book about Chopin by Adam Zamoyski, our best ambassador in the world, followed by the book Following Chopin, if you happen to go to Poland. So you meet some Poles outside Finchley and North London. And this is a history of Poland, plenty to read, and the leaflet about the
my
Polish
goodness.
Institute
Thank
for
you.
your husband.
Thank you. That's
We will
very
carry
kind.
it for you, don't
Very
worry.
kind. Thank you very much.
Thank you so much. It was really a privilege to have you here, and thank you very much for introduction. I think we're probably going to leave the questions now, but we are going to invite you all for lunch to Ognisko restaurant. It's a short walk from here when we can informally have a discussion. And if you have more questions, you're welcome to ask Professor Dacre. Thank you so much for being here, and please join us for lunch. So I think we can all slowly take our short walk to Ognisko Polskie, which is just down Exhibition Road. Ah, yes. Thank you so much.
Okej, to dziękuję wszystkim Zoomowiczom. Kończymy nagrywanie.